Thanks for coming. We spoke earlier as well, and we'll keep it Nepali, English, whatever you want, however you want. I know we'll keep it bilingual. Right at the get-go, हामी चाहिँ हैन कसरी चाहिँ deprived भयौँ कि roboticsबाट है how did we not get robotics in Nepal when robotic operations were done 25 years ago in the Western world, or even in India like 15 years ago? How did we get deprived from it? But finally, it's here. I know what had happened. Like just a backtrack of it.
Yes, like you say, the robotic system has been around for more than 20 years since the introduction of the Da Vinci system by Intuitive in California in the US in year 2000. Obviously, there was a lot of work behind it for many years before it could be applied in the general public through kind of FDA approval, which was in year 2000. Obviously, it took off in a big way in the US. The US government, the US funding and the health system is on a kind of different scale altogether. अनि त्यहाँ चाहिँ अब urology, gynecology, GI surgery सबैमा चाहिँ त्यसको चाहिँ एकदम राम्रो success भयो. And they had the funding for it. Rest of the world were a little bit skeptical. Obviously, in the UK also, it was around 2007. In India, 2000. Even in India, in the All India Institute of Medical Sciences, I think they quickly cottoned on to this and wanted it.
The Da Vinci system, right?
System.
Show everybody the Da Vinci system that we're talking about, right? So this is one of the first robotic systems used in the world.
Yes. So this one is the single port system, which is one of the latest ones. Here, everything comes through one port instead of 3 or 4 different ports. All the instruments, including the camera, which you can see is like a cobra's head. It moves in tight spaces. You've got your arms where you use different instruments like scissors.
So that is pause it, boys. So that's the camera on the top.
Yes. So that's the camera. This is one of the latest single port systems made by Da Vinci. So so you could have your very big operation done through 126 millimeter one port. Okay, like your prostate cancer operation or your kidney cancer operation, where you just remove part of the kidney, or you do some fine kind of kidney pipe pyeloplasty type reconstruction operation. This could be done with one incision. So this is the future, and this is where we are headed in terms of big complex operations, particularly inside the abdomen. Whether it's GI surgery, removing a bit of the bowel, gallbladder, that kind of thing, or gynecology.
Or what my dad got, the hernia operation.
Hernia operation, yes. So that could all be done through one port. That is where the future is in surgery, and the future is already here, because this single port has already been around for around 6-7 years in the US. Obviously, the ones that we use worldwide is the multi-port system. That's the most common one available throughout the world. So to go back to your question, why has it taken so long? In every health system, there are a number of reasons, and one of the main reasons has been financial. Obviously, the US financial system is very well supported.
It's robust.
It's very robust, and they support new applications, which may be expensive, but actually, one of the reasons why this has been successful is because it is very precise, it is very accurate in terms of the fine movements that you need inside the body to remove, for example, tumors with clear margins, or to protect tissues, to align, reconstruct, suture, anastomose joints in a very fine and precise way. And then this translates to good outcomes with very low complications. And this has been proven over the last 20-25 years for a lot of different operations done robotically. So that is why in different systems, what you don't want is your patients kind of coming back with complications, readmitting, reoperations and all this. And the patient's not happy. It's not good for the patient. And it also adds to the costs in the bigger picture for the insurance payer, or if it's out of pocket through आफ्नो पैसा खर्च भए पनि.
Yeah.
So for multiple different reasons, this is a success story worldwide. So yeah, for example, in the UK also there was skepticism
In the beginning.
In the beginning, to say, is this a gimmick? Because the UK health system, for example, which is where I spent a lot of time initially, there was skepticism, big question marks. Is this going to cost the government a lot of money? How are we going to fund this? तर चाहिँ अब त्यो सबै कम्प्लिकेसनहरू, length of stay in hospital, transfusionहरू, infection riskहरू, pain, the recovery, everything is so much better that in the bigger picture it's worth the investment. होइन, त्यो भएको हुनाले चाहिँ अहिले फास्ट फोरवर्ड अब 10-15 years, युकेमा पनि 100+ वटा सिस्टम छ त्यत्रो सानो कन्ट्रीमा. डाभिन्ची.
Google एकसो गरेर चाहिँ Google on the AI mode, when was Da Vinci system created and who created it in the US? Let's Google that and let's find that out. I'm sure you already know that.
Absolutely. In the 90s, they did a lot of work. And they had a lot of collaborations between a lot of companies to bring about intuitive. They went through their clinical process, and the system that they launched was FDA approved in year 2000, I believe.
1995, Dr. Frederick Moll and John Gordon.
Yes, in the 90s.
Freuden and Robert G. Young, they created the system.
Yeah.
Da Vinci surgical system. Right, that's the system that you were trained on.
Yes.
You were trained on.
Yes,
one of the systems that you were trained on. Dr. Pratik, let's get started with a little bit of your history. I know, of course, Hazur, you studied in Xavier's, if I'm not mistaken.
That's right. Yes,
and then you headed to the UK because I believe Chief Saab at that time was somewhere in the UK as well, and then the family moved.
Yes,
along that line.
त्यही भएको त्यही हो. त्यहाँ म यहाँ एसएलसी दिएको थिएँ. So I was just waiting for my exam results, and my father had been appointed as military attaché in the UK for a period of 3 years. So I was very lucky in terms of my timing to kind of make the extra step in terms of higher studies. And thankfully, I managed to get a scholarship. A full academic scholarship in Ardingly College, which is one of the big colleges in the UK, and that's why I took up some subjects in the area of interest, which was sciences, A-level sciences, and based on that, I was able to apply to
UCL
medical school.
Fantastic! You went to the University College of London, if I'm not mistaken.
Yes, University College London, University of London. Yes.
And how did that shape you as a human being there and studying there? Honestly, I'm asking you this.
Yeah, I mean, I felt a sense of achievement because I couldn't have imagined getting into a kind of top-class university
in the world.
In the world, it's one of the kind of top-ranking ones. So I was very lucky to get a place, particularly to study medicine there. And I studied hard, but I was also into sports. So I played a lot of football. I represented the medical school and the university all throughout the kind of 6 years I was at med school. I also got the opportunity to integrate an extra degree. So if your basic sciences are good enough, and if you're interested, you have the option to study for an extra year to get an extra degree. Yeah. So that was in surgical oncology in the Department of Surgery, which is what I was interested in, and that also kind of helped me in terms of also furthering my academic interest with a PhD in uro-oncology in due course after I qualified. So, yeah.
And at one point, I was reading up. Obviously, I was reading up on you as well, and then there was what was the thing that triggered you and said, that caught your attention? That all right, I need to go ahead and jump into robotics. What was that trigger factor? Okay?
Yeah, I mean, as you saw from the clip, people are already talking about robotics in surgery. I was interested in surgery, so I qualified in year 2002.
Exactly. So this is
in
back
the 90s,
in the day. Yeah.
In the 90s, and they were already talking about in the US they're kind of doing the robotics operations, and I the first time I kind of saw all this firsthand was around 2006.
2006.
Yeah, I was in the US. I went on a urology kind of annual American Urological Association conference. The robotics was a big thing, so I got to see live operations being kind of streamed to the audience. You could see how, the visuals were, fantastic. All the fine movements were, perfect. And you could also see the systems being displayed by Intuitive. It was a big thing in the US, and it was about to be a big thing in the UK and the rest of the world. So that really caught my attention. And I knew at that point that, look, I'm doing a lot of open operations, I'm learning a lot of open operations, and I'm beginning to learn a lot of laparoscopic operations. But that's what I need to be doing.
You jumped into the future. This is the future. Yes, that's what you thought of.
Yes, the future was already there. It was just that it wasn't in the UK at that point, but I could see it within a few years arriving in the UK, and that's what happened also. So the first time I started using robotics was around 2011, because that's when UCL obtained its robot.
Yeah.
There weren't, I think it was probably the third one in the country at the time.
And you were lucky enough to...
The second one in London. So I was in the right spot again to kind of start learning robotics.
So give me a timeline. You left Nepal in 1990?
93.
1993.
I'm getting on a bit.
No, you're all right. You're all right.
I'm almost 50 now.
You left in 1993, and then you studied your whole adult life. But you're still studying.
Yes.
A doctor never stops.
Yeah, you need to keep learning. You need to keep updating. The technology is advancing. Even the surgical robots that you were seeing, the multiples. I've been through kind of all the generations of Da Vinci systems, Da Vinci S, SI, XI, X, single port that you saw in the video clips. So I've used all of those platforms.
Let's do it, Haitha. Let's do it one by one. I hope you have time, all right? The first one that you used back in 2006, you saw in 2006 was?
2006 was the Da Vinci.
Da Vinci.
Yes.
Okay, Da Vinci 2006 got it. Let's show everybody the progress, because I know this conversation is going to go worldwide. So let's show it to everybody. All right, some doctor sitting in San Francisco might be listening to this. So let's break it down. Da Vinci 2006. That was the first one. So
Vinci, I believe it was Da Vinci S.
Da Vinci S 2000 S. Yeah.
And then we had the Da Vinci SI system after that.
Oh shit,
and
this
is
something else. All right. Which one do you think you saw for the first time back in the day?
It was maybe just the Da Vinci system.
Da Vinci system.
The one that I then used in 2011 was SI.
All right. So these were one of the first ones, right?
Yeah.
That looks so old.
Yeah. Yeah, and you can understand the skepticism, right?
Of course, look at all the computers and all the jargons there. All right, now let's cut to 2011 when you operated on it for the first time in the UK.
Yes, I was learning it. I was beginning to get some hands-on.
What was the system called?
SI.
Da Vinci System SI 2011, right?
Mm-hmm.
Let's see, 2011. So this is the one. It looks a little bit more pristine.
Yeah, this is more
sorted out, a little bit from the future.
It's like looking at different generations of cars, like models of cars and bikes or what have you. So there are refinements. It's just not the aesthetic. It's just there are designs to make it more ergonomic, more comfortable for the surgeon too. In terms of the headrest and
I know, I see the chair. I can understand from that chair itself. That's some of the best chairs in the planet.
And I believe the latest Da Vinci system, which obviously has just come around in the last few years, and I've been in Nepal for 5 years, so I've not used that one yet, has a mobile phone kind of
do the Da Vinci system 2020 ko गर न 2020 को हेर न अब हैन, then you will know exactly the latest one 5 years man. These are the ones that you used. These are the latest ones that probably you used then.
So the SI is still the old one.
Okay.
And the XI after that.
XI. So these are the new ones. That looks something out of a sci-fi movie. Very, very interesting. Very, very interesting. 2025 got it. The Da Vinci system. What is it called now?
Da Vinci 5.
5. There you go. Da Vinci 5.
V.
5.
Yeah,
There you go. This is the one.
Yeah.
This is the latest system, American system, the ones that come from the US.
Yeah. So this is even more ergonomic. I haven't used this one because this is the latest one.
You've been here?
I've been here for,
for 5 years. 5 years
but
now.
I've used all the ones before that one. So here the headrest is also more upright to make it more ergonomic.
So what kind of operations do you do with this? Give me a ballpark, something that you do it in a very regular basis.
Yeah. So in Nepal, kidney operations are very common. So kidney removal, kidney mainly for cancer, but also if the kidney is non-functioning, it's troublesome because of previous infections or for whatever reason, blockage or stone disease.
Yeah.
It may be non-functioning, causing problems. Then you need to remove the kidney. That's called simple nephrectomy. So that's also quite common finding in Nepal. So if you need to remove the kidney, you can do this robotically. If you need to remove part of the kidney, because there's a growth which doesn't require removal of the whole kidney, then you can just remove that part robotically and then join the kidney back again. So that's called nephron sparing or kidney sparing operation, which is obviously much better for the patient. And this is something that you can tackle robotically, right? So if you try and do that laparoscopically for more large endofitting, meaning it's kind of growing inside the kidney, then it becomes technically very challenging.
Yeah.
So that kind of more technically challenging operation becomes more doable, more successful robotically. And you've removed just the cancer, and protected the rest of the kidney, which is good for the patient, right? So
of course
you'd want that.
And the recovery time is going to be shorter
too, compared to big open cut or compared to laparoscopic, where you may end up having to remove the whole kidney because it's more technically challenging to put it all back together if there's bleeding or for whatever reason it seems more invasive or growing into the kidney. Then you need to remove the whole of the kidney. But if you do it robotically, you've got a very good chance of being successful, even for what looks like, technically this may be a problem.
What's the margin of error chances? Honestly, I'm asking you this. Doing it with your two hands, obviously this is doing it with your two hands too, but robotically.
Yes.
What's the difference, give or take?
This is accurate within millimeters. So this is that precise. Your incisions, your suturing is extremely accurate. And one of the other advantages that robotics also offers is that unlike compared to laparoscopically, once you're inside, the instruments there's tremor filtration. So there's no shaking of the instruments either. So it is extremely precise. You can suture with your left hand, right hand, perfectly. So it's extremely precise.
Okay, this is for my tech fanatic friends all around the world. In another 20 years, when we sit like this together,
yes,
do you think you will be needed to do that operation? Or will you, with your own hands, or will you be needed just to observe in another 20 years?
Very interesting question. And I think that's the kind of $1 billion question right there. I think the companies, the tech people, a lot of people in the medical field are also quite confident that, seeing the rapid improvement in technology over the last 10, 20 years, that in the next 10, 20 years, a situation like that may be, quite a common scenario where you're doing certain operations, completely almost in an automated fashion where, the surgeon isn't physically operating, kind of programmed the robot to deliver the operation. So I wouldn't say no. That's maybe possible.
It'll go into autopilot mode itself.
Yeah, something like that. And there are already certain operations which are being done like that. So
like which ones?
there's not for prostate cancer. So, for example, for benign, non-cancerous prostate growth, the conventional way that we do it is we go in with the telescope through the water pipe, in the male water pipe, to the prostate and core out the prostate. So there's a robotic system which is already doing that within minutes.
Without human interference?
Without, during the operation. Something that would normally take 45 minutes, 60 minutes to do, with the surgeon actually scraping out the prostate to bore out the prostate to create the improved water flow, urine flow. So that kind of operation is already being done. And this is already clinically approved. And maybe, a commonplace in the next 5 years, even Nepal, India, too. So that's a different kind of operation, but there are certain operations where, that could be applicable.
Okay, so let me pick your brain on something else. Do you think with the help of artificial intelligence, whatever knowledge you've gained in the past almost 48 years of your life, right?
Yes.
That knowledge and the knowledge of combined professionals from all around the world can be put into this system, and maybe the system could just do it by itself in another few decades.
I don't say, I wouldn't say that's not possible. I think that, that may be possible. Where there is no doubt is in terms of diagnostics. That's already proven itself in certain scenarios, contexts. For example, AI in pathology or radiology, where the pathologist needs to, for example, I send them a piece of kidney or a piece of prostate, and they need to kind of look at different slices, spend hours
going through
it, making sure that it's exactly what they report. So they apply a lot of different staining, and there's a lot of, it may take a few days to kind of do that, and then it may take them a few hours to actually do a detailed report. That process is already being kind of streamlined and made more efficient through AI. Right? So, for example, that's pathology. So, for example, in radiology, looking at X-rays, CTs, MRIs, because if the AI system can categorize it into, okay, this is clearly normal, which may be 90% of the cases. Let's say, for example, out of 100 X-rays, 90% of them are completely plumb normal. There's no way that they can be. So they've, through the deep data and through all the information that they have, they can categorize it, confidently into no need for the radiologist here because it's all normal, right? There may be also the remaining 10% may be something that the radiologist needs to look at. So they can kind of flag up those 10% of cases to say, okay, well, clearly, 1 or 2% of these are clearly abnormal.
Right.
This is significantly abnormal. So the radiologist will definitely look at that and quickly come to the kind of conclusion there too. And the other kind of 7-8%, which may be equivocal, is where the radiologist may spend a little bit more time to kind of do some further tests to see whether that's what it is that it's flagged up. So that's where I think it will be extremely efficient
in the coming decades. So it's just making the life of the, let's say for now, since we're talking about the radiologist, he or she, their life easier, so that they could actually spend time on things where they're actually needed.
Yeah.
And just get rid of the ones which you're like, all right, these people are fine.
Normal,
yeah. Interesting. I saw a video, this is some time ago, of a breast cancer. I don't know if you've seen this or not, where the AI detected that this person's going to probably have breast cancer in another X amount of years, but automatically detected breast cancer. What do you call it? I don't know what it's called. A lump, if I'm not mistaken. Mm-hmm. The AI system detected it. So that tech we already have.
Yeah, that's amazing. That's the kind of improvement in the technology that's already here. So
Oh yeah, there you go.
Yeah. So
images show AI detecting breast cancer 4 years before it was developed. We gotta watch the ad, buddy. It's okay.
Yeah, that's amazing, isn't it? I mean, I didn't know that, but I wouldn't be, again, like I said, I wouldn't be surprised. This is a radiology example again, where the radiologist would have looked at 100 such images, and कुनै पनि अब त्यो स्टेजमा पुग्नको लागि चाहिँ हैन, it's a natural history in the progression of the cancer. So it starts at a kind of almost non-visible, microscopic level, cellular level, which isn't at that stage evident on any mammogram or ultrasound or X-ray or whatever. I mean, it's just not going to be possible, right?
Yeah.
It needs to be a certain size and with a certain characteristic for it to be flagged up by the trained eye. So, but if you already have, through millions of such information data, the AI kind of applications applied to it, to be able to spot that.
Right now,
is amazing.
Right, exactly. Right now in 2025, we're in a time when they can just go ahead and AI could pick this up.
Yeah.
My question was earlier by 2050, the robot's going to be doing its own thing. That's going to be insane. Let's say I have what's the most common operation that happens in the world? What's one of the most common ones?
So lap chole, for example. So cholecystectomy may be a hernia operation or cholecystectomy gallbladder operation.
Appendix.
Pitta thailiko. So I think that's one of the most common operations in GI surgery.
Let's say a suture, right? I cut my finger. I cut my finger on a cycling accident. What do you call it? 15 to 20 years ago. I had 4 stitches here. Some gentleman in the emergency room is like, well, let's fix you up. Boop, boop, boop. Done. Right?
Yeah.
Maybe in the future, if I have a cut like this, I could just put it in a machine and just get it done.
Yeah, maybe. I think that's that may well be the case. I wouldn't be too surprised. Like I think 20 years ago, the example that you just gave in terms of the breast lump or very kind of almost subclinical lump that most people would miss, most even trained radiologists would miss being detected by AI. So why is this not going to be possible? I think it may be possible in 10, 20 years' time where
I'll probably have a better scar, a fine-looking scar, not a roughed-up one that was done quickly. Let's fix you up right away. I did this without any,
local anesthesia.
Nothing.
Yeah, because sometimes the local itself is more painful than actually putting a few stitches.
Yeah, I'm not going to name the hospital, but they looked at it and they were like, is it hurting? Yeah, well, we gotta fix you up right away. So let's just get into it and let's just get it done. No, very interesting. Let me come back. So you went to the US. You obviously got trained in this. You got in the UK. You got trained into it. What made you actually see? You had a good life. You have a good life. You had a very great life in the UK too. What made you switch and decide to be like, all right, let's see if we could do this in Nepal and come back?
Yeah, a number of different reasons. I think I've always wanted to come back to Nepal. Also. I wanted to use my training, my experience, my technical skills, and apply it to Nepal because this is particularly in my profession in surgery, this is the way that it's headed. Like we've just been discussing. Right now, last 20-25 years, worldwide, बिस्तारै हुँदै गइरहेको छ. बिस्तारै भन्दा चाहिँ rapid. Exponential रूपमा गइरहेको छ. नेपालमा छैन. It's not here yet. So and that kind of gave me more impetus, more kind of a drive to kind of kickstart this. Obviously, I've been here 5 years, and it's taken a few years to kind of get everything set up properly to implement this. And to skepticism saying about different sector, it's स्वाभाविक हो. अब even त्यत्रो अब country India, UK मा त अब question markहरू थियो भनेपछि initially initiate गर्ने बेलामा चाहिँ विभिन्न किसिमको चाहिँ स्केप्टिसिजम हुनु नेचुरल नै हो. सो अब नेपाल इज नो डिफरेन्ट, सिस्टम इज नो डिफरेन्ट. सो तर चाहिँ आई थिङ्क that's those are the factors. Plus also family factor. It's always good to be with your family, and thankfully I came back at a stage when I hadn't completely settled in the US. Like we were discussing earlier, once you start settling completely with a young family, and then it becomes more and more difficult increasingly to come back. So I think I've kind of timed it right.
Yeah. Oh, go back. Oh, there you go. You're cute. Oh, what's his name?
Shriyant. So yeah, he's 9 now.
Okay. This was from some time ago, I believe.
Yeah, this is last
year. Yeah. Sorry, you were saying?
Yeah, so I think family reasons too. So,
Doc sir, this is for all the doctors and all the professionals and all my friends all around the world, right? Nepali who've gone abroad. You went in 1993, give or take, 27 years, and you were away for 27 years from Nepal. Right? How does it feel to come back? Like, this is a very personal question. फर्केर आउने के अब म बस्छु. I've seen the world. I've studied. I've got the best degree that anybody could get in the planet. I've studied all my life. I've worked all my life. Now let me come back to Nepal from the West. Honestly, I'm asking you this. How does it, deep inside, it's a big sacrifice that you're making for your family too, maybe for all the things that you've achieved, it's a big uncertainty. Like, how did it actually feel, and how did you make that jump to be like, all right, I'm back home, I'm going to come back to Nepal?
Yeah, I mean, initially the question mark to huncha. I've worked all my life. Pretty much, I haven't previously worked in Nepal. Nepal ma kaam gareko थिएन. अब त्यही medical school देखि नै म postgraduate level सबै UK र US मै थिएँ. त्यही भएको हुनाले चाहिँ अलिकति hesitant चाहिँ थिएँ initially. But thankfully, through the support of my wife and my immediate family, on both sides of the family, they were very supportive to say, look, don't worry, just come back and just start your thing. We'll support you in whatever way possible. So that kind of gave me the confidence to come back and start working in Nepal. And I've really enjoyed it over the last few years. Worked in a lot of different hospitals, and and as you know, it's just starting robotics program just this year has given me a big sense of satisfaction, because now I'm already kind of doing the operations that I've been doing for many years, and making that clinical service available to the deserving Nepali people. In India and China, there are hundreds of robots already over the last 10-15 years. So it's about time that Nepal ma pani aba yo ta hunu paryo ni. So why do patients need to go abroad to get this type of operation done? It should be available in Nepal. Plus also the second side is to also train. यो चाहिँ जहिले पनि अर्को big question mark चाहिँ अब manpower. अब trained robotic surgeonहरू पनि चाहिन्छ. One of the reasons that I think you were asking me earlier why कति यहाँ किन आएन, किन यति समय लाग्यो भने, also the availability of trained personnel. So these are not inexpensive. They're quite expensive. So there will be hesitancy from the corporate hospitals or government hospitals to say, well, actually, who's going to be doing this? Because त्यहाँ अलिकति pool of trained people चाहिन्छ. So this is an opportunity for me to also train other colleagues आफ्नै फिल्डमा, urology, GI surgeonहरू, gynecological surgeonहरूलाई उहाँहरूलाई पनि बिस्तारै robotics मा चाहिँ exposure दिने, training गरायो भने उहाँहरूको त्यो it builds a kind of pool of doctors who are able to deliver this. So transferring and giving back, or paying forward, whatever you call it. So I think that's also something that gives you a sense of satisfaction that you're kind of helping fellow surgical colleagues, I know, whilst at the same time, providing that clinical service to the patients.
There's a friend of mine, हामी एक ठाउँमा बसिरहेको थियौँ and we were having lunch, होइन डाक्टर साहब? And he said something to me that's going to stay with me for the rest of my life. We're just casually talking, होइन, अनि कुरा गर्दै थियो. डक्टर पढ्नलाई महँगो पर्छ कि यहीँ महँगो पर्छ झन् विदेशमा त झन् अब let's not even get there, होइन, the amount of money you have to spend, होइन. Time is one side, but if you don't have a scholarship, just to the amount of money that you're going to spend, right? What he mentioned to me was, Sanjay, म डक्टर पैसा कमाउनलाई बनाएन नि, म डक्टर मान्छेलाई मद्दत गर्न बनायो नि, होइन, and that stayed with me for the rest of my life, होइन. And there are certain professions that you get into to serve your fellow human being, होइन. And that's the sense that I got from you when we spoke earlier, होइन. And I believe that's it.
Absolutely. There is no greater satisfaction than being able to kind of use all your knowledge and skills for the benefit of the patient who requires that from you, I know. And also the other aspect is teaching, training others also, because that's what that's how you learn. So if you get an opportunity, it's also always deeply satisfying to be able to kind of continue that and give that kind of service to your colleagues too. So patient-हरुको लागि पनि हो, fellow of a fraternity colleague-हरुको लागि पनि हो. So I think that's those are the things that kind of gives you the reason to kind of push forward and do these things.
Yeah, and it's rooted in your family itself. Father served all his life, so I'm sure that aspect is always there too.
Yes.
Right. All right. Let's jump into the new stuff, right? The latest tech from China. If that's okay with you.
Yeah, absolutely.
Let me show everybody this. हामीले हजुरले ट्रेन गर्नुभयो. You trained in the Da Vinci system, which is the American system, American robotic system, right? When did you see the Chinese medbot system? When did you first time hear about it, see it?
So I think this was towards the end of 2023.
Okay.
I was exploring, what systems could be brought into Nepal. So I was focusing mainly on the system that I was most comfortable with. I know जुन चाहिँ अब त्यो American system हो, intuitive को Da Vinci system, which is the most worldwide is the most kind of dominant, most prolific system in the market. संसारभरि त्यही नै छ. इन्डियामा पनि अहिले चाहिँ अब probably around 150-200 वटा system Da Vinci आइसक्यो होला, probably certainly more than 100.
Yeah.
चाइनामा त few hundred नै छ. So तर त्यहाँ चाहिँ अब I think probably because of our economy or a pool of surgeons or a pool of hospitals who are willing to kind of invest in this, their company side, but I think there was some reluctance.
Okay.
And this is not only myself. I think others who have kind of explored like when they feeling भएको छ त्यसले गर्दाखेरि चाहिँ alternative options. So thankfully अहिले चाहिँ last 5-10 years मा चाहिँ alternative robotic systemहरु छन्. And some of them are licensed in the US and in Europe. And so looking for those kind of safe, proven systems, I happened to bump into medbot. So I then went to China with my collaborative partner at CMC, which is Dr. Harish Nupani, the chairman of CMC. So we've collaborating on this at CMC as well as our Kathmandu project, which
the
is
new project, yeah.
New Kathmandu International Hospital, which is also going to have a strong robotics program service available. So we're looking for ideal kind of systems, and this was one of them, and this immediately caught my eye because it has a striking resemblance to the Da Vinci system. So I was thinking, how did they, manage to do this? Because there's a lot of patenting and all this, and it seems that they have managed to negotiate all those hurdles, and they managed to come up with a system which looks. Looking at the videos, looks almost exactly the same. So I wanted to try it for myself So in 2024, early 2024, I went to Shanghai and had a look and tried it.
Which hospital did you try it? Which hospital was this?
So this was their headquarters in Shanghai. Which
Medbot.
Microport.
Find out the name of the company and then also find out when did China start building their own robotic system.
Microport. So that's Microport in Shanghai.
Okay.
And they have, China has a lot of different robots. So there are a lot of different robots. This is, I believe, the only one which has the European license for safe use in the European market. So this is a very proven system. More reassuring boy. So I had to try it. So I went and tried it, and it was very responsive. I was very pleasantly amused and surprised by how good it was. Yeah. So I went back again before putting in the purchase for the system, doing a lot of operations, not in patients.
Real-time operations or?
Real-time operations in animal models.
Okay.
And I found it very just like Da Vinci. Just like Da Vinci. So there was no hesitation subsequently in kind of going ahead with this.
This is a free promotion for the Chinese medbot. I'm honestly telling you this.
And I believe in the past 6-12 months, particularly after the CE marking in 2024, the purchases worldwide have been phenomenal.
All right. So China began its initial research into robotics in the 1970s, robot prototype in 79. Go a little bit down. No, we need to find the medbot itself, right? We need to do the medbot. Okay, there you go. Shanghai, is this the one? Microport Medbot Group. Is this the one?
Yes.
All right. So they came out with, I believe the one that we have in Nepal is called Taomai.
Yes. That's the one. That's the one
that we are using in Nepal.
We're using right now.
Taomai, and laparoscopic surgical robot, basically. First domestic four-arm laparoscopic robot to be put into the clinical use in China, and then now in Nepal, thanks to you and the entire team. Yeah. When did we actually get it here in Nepal? And how much, I'm sure it costs a lot of money, right? Was this Chinese, was it funded by the Chinese government or was it we bought it?
No, we bought it. So this is a private company. So this is, I'm sure they have the kind of necessary support and the backing from the Chinese government. But more importantly, it's gone through the due process in terms of safety and so on. And it's kind of gone through the European safety checks, and it's approved for use in Europe.
Yeah,
which means that a lot of Western countries are now going to already kind of beginning to use this system.
So they're going to go ahead and adapt it, right? Were we one of the first countries to bring it here in Nepal, or did China supply it to other countries too? If you know this.
Yes, so it's already in use in India, Pakistan, Philippines, in the Middle East, North Africa, South America, and in Europe and Russia. So there are a lot of countries already using this over the last few years, and I think I can see its use being almost kind of exponential in the next few years. As I like to kind of think about, how BYD was compared to Tesla, some 5-6 years back, and move forward 5 years, and BYD has proven itself. And this is not, I'm not supported or funded by BYD, but it's just an observation. So I think probably something similar is going to happen in the surgical robot market, where competitive systems which are safe and which are licensed are going to get increasingly more licensed and become available and affordable to the rest of the world. So
basically, since 2011 till 2021, let's say, for 10 years, you were using one specific system called the Da Vinci, and then now you're using this new system, called medbot, which is very similar to what you were trained on.
Yeah, absolutely. It's got a very similar performance.
All right, question to you. If we had bought the Da Vinci system in Nepal, would that be similar price range, or would that be exponentially expensive for to us?
It would be a little bit more expensive.
Okay.
So to put it in perspective, there are robots which are around $1 million US. This one is just under $2 million US. So the intuitive one is 2 point something. The Da Vinci system is, I think the latest one is around 2.2 or 2.4 million US dollars. This one here, the Chinese one, is around 1.6.
Okay, so again, I don't like discussing business with doctors, but again, I have to do this. Do we pay taxes on stuff like this?
Yes.
Do we have to?
Yes. I think at the moment, this is the standard taxes is there for this. So we had to pay the full 18% or whatever it was to bring this into the country.
Okay.
So there needs to be a provision, I think, hopefully in the near future, where particularly because this is being used for the best applications are being for cancer operations, and particularly if it's set up in government hospitals, for example, I think it would be
what we were talking earlier.
Yeah, what we were talking earlier. It would be beneficial to kind of reduce the taxes.
Okay, now let me do the math in this. I know how many people. Okay, हामीले ल्याएको 2025 मा. So we got it 6 months ago? When was it?
Few months, around 3 months.
Okay, 3 months. So we got the medbot system, Nepal's first robotic system. Can I say that?
This particular one, I think credit does go to BNB Hospital for starting with the Indian system last year. Towards the end of last year, they used a system called Mantra, which is made in India.
Mantra?
Yeah. So that's the SSI Mantra system, which they installed towards the end of last year in Kathmandu. So
so
BNB are using the Indian system, and we're now using the Chinese one.
The Chinese system. Interesting. Find out the Mantra system though, because Dr. Vivek is a very good friend of mine, and Anil Dai is a very good friend of mine, and I will mention this. They did a surgery on my mom, but again, it was something very different. And since you brought it up, I want to say a big thank you to BNB Hospital for doing such a fantastic surgery on my mom as well, and for such fantastic service. You've been there, right?
Yes,
at BNB.
I've been there, but I haven't used this Mantra system. It's got a different kind of platform. I think that's probably the gynecologist.
Find out what Mantra surgical robotic system is. Let's have a look at that.
You can see the kind of significant differences in terms of the platform here. It's an open platform. You're using 3D goggles.
Yeah, Mr. X, just copy SSI Mantra and then just show us what it is. The images so that everybody. Okay, this is made in India then.
So this is all the arms are separate.
Go to that YouTube video. Go to that YouTube below. Yeah, that one. Okay, so this is from India.
Yeah, this is from India.
So it's developed from India. Is that what you're saying?
Yes.
Interesting. How robust is this compared to the ones that you've used, the Da Vinci and the medbot?
So I've personally, because of my experience with Da Vinci, having used so many different generations of Da Vinci systems, I feel more comfortable with Da Vinci or something that works like Da Vinci, right? So hence my kind of level of comfort with the current robot that I have. This is designed slightly differently. Although the principles are the same.
Yeah.
So I think that's one of the main reasons that I went for the one that I've gone for.
Yeah.
And of course, the other reason being that it is kind of European safety marked system, which is proven safe for use in the Western world.
True. Got it. Now let's do the math earlier. So in 3 months, how many doctors have you trained so far?
So there are 2 GI surgeons who are getting gradually trained up through dry lab and wet lab and live operating, to the extent that over the last couple of months we've done a handful of straightforward, run-of-the-mill kind of operations within GI surgery, which means we've done 4 cholecystectomies, which is removing the gallbladder.
Yeah.
Normally that's done on a daily basis in most hospitals in Nepal, throughout Nepal, laparoscopically. Lap chole. That's a half an hour, 45-minute kind of operations usually for experienced surgeons. And these are, quite experienced surgeons themselves who can do a lot of complex open and laparoscopic operations. For them to now gradually start doing initially the more straightforward cases robotically is great, and hopefully in the next 6-12 months, within a couple of years, they will be doing a lot more complex operations that this kind of system delivers on, worldwide. So that's where I want to see this advancing, that more and more complex operations are being tackled robotically.
Yeah.
And so GI surgeons, gynecology surgeon is also gradually getting trained. In the meantime, also training my fellow urology surgeons. There are 2 urological surgeons who are doing, open and laparoscopic operations.
Yeah.
So trying to get them to getting them trained up to. Myself, I've of those 18 cases, I've done 10 urological complex operations, including prostate cancer operations, kidney operations, reconstructive pyeloplasty operations. I feel comfortable doing them because I've been doing those for many years. But I think it will, hopefully in a matter of months, certainly within a year or 2, I can get fellow colleagues to start doing those cases too.
Fair. My only thing that we talked about earlier was if in every single province, in every single hospital, the main hospital in those provinces, if we can have robotics like this, any robotics. I have to say, any robotics. We could get the Da Vinci, we could get the medbot, we could get the, what is that, mantra system, any of the systems, and have trained doctors. At the end of the day, we'll win.
Absolutely. I think that has already proven itself in the world stage. US मा मात्र अब उनीहरूको चाहिँ अब इन्स्योरेन्स पोलिसी, उनीहरूको चाहिँ गभर्मेन्ट पोलिसी यताउतिले गर्दाखेरि चाहिँ अब सक्सेस भएको भन्ने इनिसियल चाहिँ एक्सपिरियन्स थियो, कमेन्टहरू थियो. अनि जहाँ पनि त्यो चाहिँ रोबोट इन्ट्रोड्युस गर्न थाल्यो, वेदर इट्स द युके, युरोप, इन्डिया, जहिले पनि क्वेसन मार्क हुन्थ्यो यो चाहिँ हाम्रो मार्केटको लागि अलि होइन. अब जस्तै अब युके सिस्टममा अब इज कम्प्लिटली नेसनल हेल्थ सिस्टम, गभर्मेन्ट फन्डेड, त्यहाँ चाहिँ अब यो त महँगो भयो, यो त हाम्रो पेसेन्टले, हामीले गभर्मेन्टले थाम्न सक्दैन भन्दै अब फास्ट फरवर्ड 10-15 years they've got 100+ robots in the UK. India पनि फास्ट फरवर्ड 10-15 years there's probably around 200 robots. So जुन पनि हेल्थ सिस्टममा चाहिँ यसले चाहिँ यसको चाहिँ एफिसियन्सी र सेफ्टी, यसको चाहिँ फाइदाहरू चाहिँ प्रुभ गर्दै आएको हुनाले अनि चाहिँ ओभरअल पिक्चरमा चाहिँ इज मोर कस्ट इफेक्टिभ फर हुएभर इज पेइङ फर इट, वेदर इज द हस्पिटल, वेदर इज द पेसेन्ट, or वेदर इज द इन्स्योरर. त्यो कन्टेक्स्टमा चाहिँ यसको चाहिँ सक्सेस स्टोरी भएको हुनाले चाहिँ अनि वर्ल्ड वाइड यसको चाहिँ एप्लिकेसन भइरहेको हुनाले चाहिँ आई थिङ्क त्यो नभएको ठाउँमा चाहिँ इट्स अभियसली त्यहाँ स्केप्टिसिजम होला, फर इक्जाम्पल इन नेपाल. बट इट्स अ गुड थिङ द्याट BNB started it last year, and it's a good thing that we've also, with a different system, started it. And whichever system you use, I think ultimately it benefits the patient, and it benefits the system as well, because it becomes more cost effective for the system to readmission or problem or
and definitely right now, if the Chinese friends are listening as well, send us a few, right?
Absolutely. They can easily afford it, and then if it's made available to, like you were mentioning, different zones, different big hospitals,
all across Nepal. I personally don't want anything to be restricted just to Kathmandu.
Absolutely.
At one point, I'm sure the MRI machines were just restricted to Kathmandu.
Yeah.
And now you can have MRI machines. I'm sure you have MRI machines in every single part of the country.
Yeah.
So over time, like you were saying, India ma suruma po ta garo bhayo cha. Ahile ta India ma jata pani cha एउटै hospital ma 3-4 robotics system cha bhane. In another maybe 10-15 years, if we have robotic systems all across इलाममा देखि लिएर माथि धनगढीसम्म जता पनि भयो भने त कसैले पनि विदेश के भन्छ त्यसलाई इन्डिया अथवा थाइल्यान्ड अथवा सिङ्गापुर तर्फ लाग्नु परेन पैसाको हिसाबले सोधिहाल्नु ल म होइन एउटा जस्तै अघि न we're talking about prostate cancer if I'm not mistaken होइन to do a surgery like that let's say if it costs 5 lakh rupees for example होइन त्यो कुरा चाहिँ रोबोटिक्सले गर्नु पर्यो भने पनि त्यो एकदम ड्रास्टिक प्राइस डिफरेन्स हुन्छ कि के हुँदो रहेछ
सो अब इन्डियामा त त्यो 5-6 lakhs रुपिज आइसी नै पर्छ नेपालमा चाहिँ probably अब 5 lakhs होइन going to be a little bit cheaper than that I think certainly हाम्रो हस्पिटलमा चाहिँ अहिले चाहिँ currently अब around 2.5 मा अवेलेबल गराइरहेकै छौँ robotic radical prostatectomy होइन so I think that's significantly better for the patient in terms of cost कतिपय प्राइभेट सेक्टरमा त त्यो रोबोट नगर्दा पनि त्योभन्दा महँगो पर्न जान्छ as we know in Kathmandu होइन so if you can get robotic operations at that competitive price range that's a win-win for everyone involved होइन particularly most importantly for the patient so I think that's where we can really make an impact.
And again, to convince the patient, convincing पनि त गराउनु पर्यो नि त that हामी रोबोटिक्सबाट चाहिँ तपाईँको अपरेसन गराउँछौँ भन्दाखेरि अब कतिलाई झन् रिलक्टेन्ट पनि हुन सक्लान् होइन सो त्यो कन्भिन्स गराउनको लागि चाहिँ त्यो नर्मलाइज गर्नको लागि चाहिँ अरूले पनि गर्नु पर्यो त्यसपछि अरू अस्पताल अरू ठाउँमा पनि रोबोटिक्स आउन थाल्ने बित्तिकै इट्स गोना बी इजियर
Yeah, I think there's a lot about awareness and part of the reason that we are having this conversation is to kind of raise that level of awareness in the general public as well as other stakeholders, other hospitals, other government institutions to say, look, this is the standard of practice in most countries worldwide now increasingly and it's expanding in a big way and it's only a matter of time Nepalma pani yasko चाहिँ आवश्यकता छ.
No, fair. No, that's very fair. I'll definitely raise more issues on that. I want to touch base on a few things different if that's okay with you and I'll take a little bit more of your time. यस्तो भयो कि back in the day obviously होइन 1993 things were different you had to go because your parents moved होइन अहिले चाहिँ and then you decide to study there it's completely different होइन अहिले चाहिँ हाम्रोमा चाहिँ हरेक सेक्टरमा कि I'm not just talking about science in every single sector everybody wants to leave झन् स्पेसिफिकली डक्टर्सहरू त झन् हामीले रिटेन कसरी गर्ने भन्ने पनि हुन्छ होला होइन when you sit down with your young colleagues होइन what's their thought process हुन्छ नि how satisfied do you think they are or do you think that they're also trying to migrate to some other country USMLE होस् अथवा अरू कुनै हिसाबले के how do we what's the thought process on that
so I think this is one of the kind of sad parts of what's going on. The younger generations, not only in medicine but across any sector, being very keen to seek opportunities abroad. And that's only natural. I mean, to जुनै पनि countryमा चाहिँ they want to kind of go see the world. Get achieve your higher degrees there, get work experience, maybe even settle there, or come back with a good international degree and find a good work here or start something here. So it's only natural to have that kind of drive, and that's a good thing. But to see it at a kind of a population level where perhaps. Not everyone is kind of motivated to, in terms of educational and experience, but also, badyata-bas. They're kind of, whether it's fed up or whether they're disillusioned or whatever. That's the sad part. So, if we have a system which is supportive and we have the right environment, across the country, and this applies to medicine as well. And one of the reasons that having technology and professionals who are trained to use that technology available in Nepal will hopefully यो चाहिँ कतिपय डाक्टर साहबहरू अब त्यहाँ बाहिर I'll go abroad and train in robotics, or I'll go train in something else. So if that's already available in Nepal, then you don't have to go through that hassle of doing a lot of exams and applications and spending a lot of time to go abroad to get that training that's available in your own country. After family-सँग बसेर आफ्नै country-मा बसेर you could get that opportunity. So it kind of reduces that brain drain, because once you leave and begin to settle abroad, because the system is geared for your success abroad once you get into the system, and particularly once you start kind of making roots in terms of young family and your children start going to school and so on and so forth, then it's very unlikely, highly unlikely that you're going to come back. So I think if we can create an environment, and this is just an example, then it will play a big role for the country. You're kind of retained a lot of talent within your country, and may also create an environment where those who are already abroad, who are kind of thinking, okay, should I go back or not?
Like yourself.
Then they find look they, for example, in robotics, it's already in Nepal, so I could go and kind of work in XYZ hospital, whether it's private or government or whatever, and I could be satisfied professionally to say that I'm using my experience and my skill in doing something good.
Yeah, and that's the ultimate satisfaction at the end of the day. One significant change in Nepal's healthcare system, हजुरले for the past 5 years, आफूले देखेको चाहिँ, one or a few changes, instant changes that we could make. What do you think it is? Instant, like छिटोभन्दा छिटो गर्न सक्ने चेन्ज. किन मैले यो सोधेँ भन्दाखेरि अहिले हाम्रो देशको सरकार अलि अर्कै खाले सरकार छ कि, अहिले के भन्छ यसलाई, फास्ट ट्र्याक खाले सरकार छ होइन, केही समयको लागि केही कुरा चेन्जेस ल्याउनु छ भने चेन्जेस हुन पनि सक्छ कि. म हजुरलाई एउटा इक्जाम्पल दिन्छु होइन. हामी यहाँ बसेका थियौँ, एकजना डाक्टर साहब र म यहाँ बसेका थियौँ, अनि डाक्टर साहबले मसँग चित्त दुखाउनु भयो. डाक्टर साहबले के भन्नुभयो भन्दाखेरि, कुरै कुरामा के कुरा निस्क्यो भन्दाखेरि, मेरो क्लिनिकमा एकजना एकदम सानो उमेरको होइन, सानो उमेरको चाहिँ एकजना महिला आउनुभयो. उहाँलाई अलिकति समस्या भयो, अनि हामीले चेक गर्दाखेरि उहाँले अनेस्टली भन्नुभयो कि उहाँको चाहिँ नेपालीमा मैले कम्प्लिटली नाम बिर्सेँ, उहाँको एग चाहिँ निकालिएको रहेछ, उहाँले बेच्नु भएको रहेछ होइन. के भन्छ यसलाई, डिम्मा भन्छ इफ आइम नट मिस्टेकन, चाहिँ उहाँले बेच्नु परेको रहेछ. भेरी यङ गर्ल. अनि पढाइको लागि चाहिँ मैले बेचेँ होइन, मैले चाहिँ गएर चाहिँ पढाइको लागि चाहिँ मैले यो अस्पतालमा चाहिँ अथवा एबिसी ठाउँमा चाहिँ मैले चाहिँ लगेर बेचेँ भन्दाखेरि जो डाक्टर साहब आउनुभयो उहाँको एकदमै मन त छुन्छ नि त कि अ यङ पर्सन ह्याड टु सेल हर एग फर एडुकेसन होइन. लङ स्टोरी सर्ट, केही समय पश्चात चाहिँ अब अहिले यो सरकारले चाहिँ एटलिस्ट यो सरकार आएको बेलामा चाहिँ त्यो कुरा चाहिँ उठिसकेपछि होइन, त्यो कुरामा चाहिँ अहिले चाहिँ धेरै काउन्टर मेजर्सहरू चाहिँ अपनाउन थालेको छ होइन. अफकोर्स देयर इज अ केस गोइङ अन एन्ड लट अफ थिङ्स गोइङ अन होइन. तर अब आउने भनौँ न, अब भविष्यमा चाहिँ कोही युवाले चाहिँ आफ्नो अन्डा गएर चाहिँ बेच्नु पर्दैन नि त होइन. अथवा उहाँलाई अवेरनेस आउँछ, अथवा उहाँलाई चाहिँ बेच्न दिइँदैन होइन. त्यो लेभलको चेन्ज त आयो भनेर चाहिँ एटलिस्ट that's one change that we try to raise awareness from this show होइन. So anything that you actually think is something that you've come in and you've seen that we could actually implement, that can be done by the current government or the future government, which you think is going to benefit everybody, especially healthcare workers? मैले हजुरलाई एकदम स्पटमा राखेँ अहिले. इन्टरनेसनल स्ट्यान्डर्डको हिसाबले पनि.
I mean, you put me on the spot. I can't think of one specific thing.
Thousands of things.
There's a lot of different things, and all those little things can add up to make a big difference. And so, for example, I would say probably a few things.
Okay.
Radical changes are sign and all. For example, how can we, on the one hand, reduce the kind of brain drain, if you like. People who are kind of in medicine or surgery going abroad. अब यस्तै किसिमको चाहिँ सर्भिसहरू चाहिँ यहीँ अभाइलेबल गराइदिनु पर्यो, कटिङ एज टेक्नोलोजीहरू. अनि त्यसको लागि चाहिँ अब के गभर्मेन्ट लेभलबाट चाहिँ सपोर्ट हुन्छ होइन. त्यो भयो भने चाहिँ they don't need to look for those kind of training opportunities going to India or Singapore or Europe or the US or Australia. Because त्यहाँ गएपछि probably 98-99% of the time they're not going to come back होइन. त्यो loss भयो होइन. एउटा कुरा त्यो भयो. अनि दोस्रो कुरा चाहिँ the flip side of that is, if someone's already there for the last they went there 5 years ago and they haven't quite settled there and they're thinking of coming back, how can you create an environment for them to come back? Obviously your systemहरू भयो भने चाहिँ they feel more comfortable, but अलि त्यो regulatory हिसाबमा पनि यो चाहिँ उनीहरूलाई चाहिँ सजिलो गराइदियो भने चाहिँ whether they want to be at an academic institution, उनीहरूलाई चाहिँ होइन अब आफ्नो पढेको कुराहरू आफूले चाहिँ ट्रेन गरेको आफ्नो एक्सपिरियन्सहरू चाहिँ त्यहाँ सेयर गर्नु चाहिँ सजिलो बनाइदिने environment, whether it's academic positions होइन अब यो युनिभर्सिटीमा टिचिङ हस्पिटलहरूमा. अनि त्यो if you I think set up a kind of favorable position where they don't find it difficult to make an entry at a proportional level through their experience, academic achievement or whatever that is.
Outsider feel gardenu bhayena.
So yeah. So I think that's another way that you can kind of incentivize and get people to feel that they want to come back. That they are supported by everyone to bring their kind of expertise back and share it with fellow colleagues.
License ko hisabले ke huँदो रहेछ डाक्टर साहब? Just say, for example, you stayed there for such a long time, होइन? Once you came back, you had to give another exam to be a part of the Nepali system. के कस्तो हुँदो रहेछ?
Absolutely, because I've never worked in Nepal before. So, for example, I'm licensed to work in the UK, European license, UK license, which automatically means that a lot of countries, whether it's the Middle East or Australia or Singapore or or Canada, you're allowed to work very easily. You'll get a license very easily in that specialty. Secondly, then you have a separate system in the US where you do need to go through their system because everyone in the rest of the world is trying to perhaps get in the US. So obviously, naturally, they have a kind of their own system, which is a very rigorous process of a lot of exams, which everyone has to go through. So obviously, US license. So if you have that level of accreditation worldwide where you practice and where you have the license, then I think it's useful to have that recognized in a kind of seamless way, so that you feel welcome and you don't spend a lot of time trying to kind of negotiate the exam process. But so I think those things need to be in place. I think there are already a lot of amendments which have been made in the last few years through the good work of the NMC, and I'm sure they will continue to make those amendments to improve our system, to make it more easy for those who are outside to feel more welcome and to come and provide this service in Nepal.
And I'm glad that you decided to come back, despite of being anywhere in the world. You could make a life for yourself anywhere in the planet, and probably not go through the hardships that I'm sure you've gone through here, but you've decided to come back and you've decided to serve Nepal. And त्यसको लागि चाहिँ thank you so much for doing what you do, and we'll talk more again in the future as well. Anything that I missed out, I didn't want to get into specific details of specific things, which I'll leave it to next time. After a couple of months, we'll sit again and I'll leave it to that. Anything that I missed out, anything that you want to talk about?
I think we covered a lot.
We covered a lot of things.
Covered a lot of stuff. So including my personal journey, my family, my
Everything.
So I think we've covered a lot of stuff.
Fantastic. You keep doing what you're doing. Thank you so much for your service. And I want to say thank you to my brother Kalyan for making this possible. Thank you so much, Dr. Pratik. And please, best of luck. त्यो medbot अनि त्यो डाभिन्ची र त्यो मन्त्र चाहिँ देशैभरि ल्याउन सक्यो भने चाहिँ म सबसे खुसी हुन्थेँ र हजुरले सबैलाई ट्रेन गराउनु भयो भने त आई थिङ्क एटलिस्ट वी वान
I think we can get there within the next few years.
Done. And then that's the thing that we're going to try to make it work. Thank you so much for your time.
Thank you for having me.